you share your slides as I introduce you. So welcome everyone. My name is Jen Balkas. I use she, her pronouns. I am your new co-host of the Lunchbox Talks, along with Roxanne Karani. I am now representing Seattle Public Health King County in the HIV, STI, and Hepatitis C program. So it's great to see a lot of familiar faces and names in our Zoom room here, as well as lots of new folks. So I'm delighted to have Dr. Sara Glick with us today. She's going to share her slides. Great, that looks awesome, Sara. So Dr. Glick is an associate professor here at UW and an epidemiologist working with us at Public Health Seattle King County. And was going to be talking to us today about Project NEXUS, findings from a survey of underrepresented people who use drugs, 9 U.S. syringe services programs. And a fun fact about Sara, as we start to listen to her, is that she was a college radio DJ in her past life. So we look forward to hearing you from you today, Sara, and thanks so much for joining us. And Roxanne is back. Sorry, Roxanne, I went ahead and got us started. So welcome.
That's great. Thanks, Jen. Technical difficulties here.
No problem. No problem. And sorry, Sara, just to give folks context as the layout for today. So Sara will be talking for about 45 minutes, and we'll try to save about 10 to 15 minutes at the end. We do have the chat. So if folks have clarifying questions, feel free to put those in the chat. But if you have larger, more substantive questions, please hold those to the end and we can have a discussion both with questions in the chat and on audio as well. Okay, over to you, Sara. Thanks.
Great. Thanks, Jen and Roxanne. I see I have some fellow DJs in the chat right now, so that's great. Hopefully I won't go into my old radio DJ voice. But anyway, thank you so much for inviting me to present. I'm really excited to be talking about the findings from a survey that my team and I have spent a lot of time working on over the past few years. And I do have one little detail that I have to admit is that unfortunately I won't be able to talk about 9 syringe programs. I'll be talking about 6 today. And I'll explain that in detail a little bit later on. But when we scheduled this, I thought we would have data from all 9 programs, but right now we only have data from 6. But it's okay. I think this will still be interesting and useful. And then I'll give you an update on the other 3 because those are wrapping up. And I did want to just say before I begin, I really want to thank my colleague, Jeremy Beckford, who is on this call. I'm not going to have him say anything, but he helped me put together these slides. And so I just wanted to thank him for all of his help as our data analyst. So as I know, there are a lot of people in this room who know this field, work in this field. So it will come as no surprise to many of you that there is still a clear need to focus HIV prevention efforts among people who use drugs and specifically among people who inject drugs. We did have our peak number of HIV diagnoses among people who inject drugs in the 1990s, and then this was followed by a long decline. And you can see in this graph from the CDC that in the mid-2010s, that decline stalled out. And if we were to extend this graph a little bit further, it really hasn't changed. So that we are no longer seeing a decline in new HIV cases, but instead are seeing this kind of bottoming out or plateau in the curve. But of course, HIV is just one of many health outcomes that we are concerned about with respect to people who use or inject drugs. I've listed several here, and I really want to call out opioid overdose in particular as being at historical high levels in our country, also in our state. Washington is currently the US state that's experiencing the fastest increase in the number of overdoses, and that's largely due to fentanyl overdoses. And so while this group has been brought together through our work on HIV, and this project, one of the main origins of it is in HIV prevention, we certainly are keeping all of these other outcomes in mind. In particular, are very cognizant of the incredible impacts of the opioid overdose epidemic currently. So just wanted to be sure that everyone knows this is not just about HIV. We are really talking about all these different health outcomes. So the US federal government and the CDC have not had a good history in support of harm reduction programs. There are still many policies at the federal level that do need to be fixed. I have been really fortunate over the past few years to work with a team at the CDC who is trying to make pretty substantial inroads into supporting harm reduction programs. And with that has come funding for several projects that I have been fortunate to be a part of that have the goals of eliminating the infections associated with injection drug use, and also in general, improving health outcomes for people who use drugs. And in order to achieve that, this funding has gone towards several projects, one of which I'll be talking about today. The one I'm not talking about is a technical assistance program that my team has been working on, that we provide free technical assistance to syringe services programs. So if you're interested in hearing more about that, please let me know. I'm happy to share more about that. And then today I'll be talking about one of the surveys that we were funded to do that is helping build a more coordinated surveillance program related to monitoring health outcomes related to substance use. And that is Project NEXUS, which stands for the Needle Exchange Utilization Survey. And Project NEXUS, as I've alluded to, is a survey among people who use drugs. So I'll be using that acronym throughout this talk. And that survey's goals are to assess drug and sex behaviors, to assess access and use of prevention services, and to monitor the prevalence of HIV and hepatitis C infection. The findings will be used and are being used at both the local level as well as the national level to inform all sorts of prevention activities for people who use drugs. And as a lot of you probably know, there have been surveys of people who inject drugs funded by the federal government. So what's new about Project NEXUS? And in the title, I talk about underrepresented people who use drugs. What does that actually mean? Well, Project NEXUS is aiming to fill the gaps in where the current surveys and surveillance systems, what their current gaps are. So one is to focus on rural, suburban, and small urban areas. Most of the surveys that have been done in larger urban areas. And so we focus on all the other sites in between. We are inclusive of both people who inject drugs and people who use non-injection drugs. A lot of surveys have only focused on people who inject drugs. So as you'll see, our survey is inclusive of both. And one of the biggest changes is that our survey was implemented through syringe services programs, or SSPs. It was staffed by SSP staff on site at SSPs. And that's different from some other surveys, which are often conducted at field site locations that are independent of syringe services programs or other harm reduction programs. They're often done at health departments, for example. So we actually worked with SSPs. So now I want to share a little bit more about our methods so you can understand how we selected the programs we work with and then what we did at each of them. So NEXUS was funded as a demonstration project. So we were basically building this ship or airplane as we flew it. And it was designed to complement another large survey of people who inject drugs that is conducted by the CDC. And so this is called the National HIV Behavioral Surveillance System, or NHBS. For those of you who are familiar with the PITCH study, which is our local version of NHBS, then you're familiar with NHBS. I work on NHBS locally. And this is conducted in 20 cities across the country. And we rotate between populations that are at increased risk for HIV. So we interview people who inject drugs every 3 years. But for NEXUS, our goal was at first to select sites that were not in NHBS catchment areas. And so I'll explain this in a little bit more detail, but we started out with 6 sites that none of which were in NHBS jurisdictions. So they were all outside of these metropolitan areas. And I'll talk a little bit more about these sites soon enough. So what did we do at these sites? Well, actually, first, how did we select the sites? So we intended to select sites at random. That was the initial goal. Can we use an established list of SSPs, which is from the North American Syringe Exchange Network, or NASEN? Can we go to their directory and randomly select syringes to participate? We reached out to programs starting in the summer of 2020, which was a pretty busy time, and programs were just stretched, and many programs told us no, they couldn't participate. We were able to get 4 programs through this cold call method, but we really stalled out. And so then we put out a rapid call for proposals to invite people to apply to be sites. And we were able to select 2 additional sites that way. And so that's how we ended up with our 6 sites. Then once we set up contracts with the sites and we conducted training with each site, staff who were on site at each SSP directly recruited their SSP clients to participate in the survey. So that was the main method, or the initial method, of recruiting people into the survey. And then once somebody participated, they were able to recruit their peers using an incentivized peer referral method, and they received $10 if they recruited somebody successfully. And then we also recruited people through word of mouth. So that was okay too. People could come into the needle exchange and say they were interested in participating, and they could then participate. So we did recruit in 3 different ways. Then if somebody was in the space and they were interested in participating, they completed an eligibility screener. And the screener and the interview were actually conducted remotely using Zoom with interviewers, most of whom were based here in Seattle. So we had a site in Wilmington, North Carolina, a site in New Haven, Connecticut. And so people at those sites were being interviewed by people largely based in Seattle. We ended up hiring some interviewers who were not just in the Seattle area for time zone reasons, which ended up working out really well. So we did all of our interviews remotely. And the CDC portion of the survey was about 20-25 minutes. And then each site could add up to 10 questions for their own local survey. So the whole interview took about 30 minutes, and they received a $40 incentive for completing the survey. And then we also, let me go through the eligibility criteria before I get on to the next step. To be eligible for the survey, somebody needed to be an adult, so 18 years or older. As I already mentioned, they needed to report either injecting drugs in the last 6 months or use injectable drugs via other routes in the past 6 months. Unfortunately, our survey was only limited to English, and so folks did need to speak English in order to participate. They needed to provide informed permission. As I'll say in a few slides, this is kind of CDC speak for informed consent. And so they did need to do basically an informed consent-like process, which we called informed permission, and they could only participate once. So those were our eligibility criteria. So once they completed the survey, then staff who were on site conducted HIV and hepatitis C testing. They first collected a fingerstick specimen for both rapid HIV and rapid hepatitis C testing. And then they also collected a dried blood specimen, which was typically 5 little dots on a piece of paper, and they had to fill those dots with blood. And then we were able to test those dried blood spots for HCV RNA, which we sent to a lab called MTL, which is based in Vancouver, Washington. So participants received their rapid test results on site, and they could then call back to receive their hepatitis C RNA results. And if they did call back to get their results, they received an additional $20 incentive. And then finally, for folks who either had a new HIV or hepatitis C test, or had HIV or hep C but were out of care, local staff were able to link them to local care options, whichever had been vetted and were considered a good fit for people who use drugs. So that was based on the local team. Okay, So I alluded to this earlier, but I just wanted to step through quickly what our ethical review process was. So the CDC determined NEXUS to be a public health surveillance activity. And so what that means is, by definition, it's not considered research. So this project looks a lot like research, but it didn't have that label. But the UW IRB made the same determination. What does that mean? It meant that the protocol and changes to the protocol didn't require ongoing IRB review because they were being written as a surveillance project by the CDC. It also meant that, as I already mentioned, we didn't necessarily do informed consent, but instead it was informed permission. But as somebody who has collected informed consent before, our process was exactly the same. It was just called informed permission. Early in the survey, we did plan to collect limited identifiable information in order to return the hepatitis C RNA results to participants. But within the first 10 or so participants, there was concern about having any identifiers in our data set. And so we actually paused the project and then completely made all of the data anonymous. We changed our age question to asking about an age group. We only collected the first 3 digits of a person's zip code. We had a code within our project that removed all identifiers. And then we did have to eliminate the option for a person to receive their hepatitis C RNA results, which meant that a lot of people did not, but we decided as a team that it was better to keep the data completely anonymous. Okay, so now moving on to some of the key findings from Project NEXUS. So I wanted to introduce our 6 sites. So we worked with 6 amazing SSPs across the country, one in Sacramento, California, one in Ellensburg, Washington, one in Missoula, Montana, one in Madison, Wisconsin, one in New Haven, Connecticut, and one in Wilmington, North Carolina. 5 of those sites had goals of 300 participants, and then Ellensburg, Washington, being our smallest and most rural site, had a goal of 150 participants. 4 of our sites did conduct more than 300 interviews. Sacramento and Wilmington did conduct more than 300 interviews. It's just that we had to toss a few of those due to validity concerns, but they did reach the recruitment goal. But overall, we were absolutely thrilled that we recruited over 1,500 people into this survey. It was set up when we were in lockdown, basically. This was largely done during some COVID restrictions in many of these places. And we were just really, really happy with how everyone rallied, and participants were really excited and able to participate. So we have a lot of rich data from this survey. So in our survey, participants could select more than one gender, they could select more than one race, and so you'll see these columns add up to more than 100%. We had 62% of our participants were men, 37% were women, and 2% were either trans men, trans women, non-binary, or genderqueer. Overall, we had a fairly diverse sample with respect to race and ethnicity, where 48% of our participants selected at least one identity that was Black, Indigenous, or another person of color. And we did, across all of our sites, see very high levels of housing instability, with 68% of our participants reporting that they had experienced homelessness in the past 6 months. I did mention, that this survey was intending to reach an underrepresented sample, and I explained some of the ways that we defined that. So did we actually reach people who didn't inject? And the answer was yes, we definitely did. Nearly a quarter of our participants did not report injection drug use. They reported using drugs in other ways. Only 7% reported only injecting, but as of course, drug use trends are moving toward, more and more people reported both injecting and non-injection of drugs. So we were pleased with the change in eligibility criteria. Okay, I'm going to walk you through this because this is a lot of data. But in the survey, we asked people what drugs they used. And so let me walk you through this step by step. First, if you focus on that little blue box there, overall, among people who injected drugs, the two most commonly reported drugs that people injected were heroin, followed closely by meth. And among people who use drugs in other ways, the two most common drugs were meth, followed by heroin. So for example, 60% of people who use drugs in other ways reported using meth. But there were very clear differences across the two halves of our country. So in the West, meth was consistently the most commonly reported injection drug, followed by heroin. And meth was also the most commonly reported non-injection drug, followed either by heroin or by painkillers. And then when we go to the eastern half of the country, we see a different pattern. Here we see that heroin is the most commonly injected drug, followed by fentanyl in New Haven and meth at the other two sites. And then crack was the most common non-injection drug at two of our sites, while meth was the most common in Wilmington. And I did want to pause here and just say the East Coast data are a little tricky to interpret because we know that what we might call heroin is often fentanyl, and participants often know that, but that is what they reported in the survey, is heroin. Fentanyl was an option, but we just know through drug testing and just other knowledge that a lot of heroin is actually fentanyl. So that's a little bit hard to interpret, but we can assume that a lot of that is fentanyl, not necessarily heroin, but still very clear differences between the two halves of the country. And one of the most novel things that we've been able to do with this survey is that we were actually able to then test the extra dried blood specimens for drugs. And so for people who consented to letting us do additional testing on their dried blood specimens, which was the vast majority of people, let me walk you through this slide. So for example, in Ellensburg, we were able to take the dried blood specimens, and we worked with a lab who conducted testing, and they were able to test for cocaine, fentanyl, heroin, methamphetamine, and xylazine. And for those of you who aren't familiar, xylazine is a tranquilizer that has been reported more and more, especially on the East Coast, often in combination with fentanyl, and can cause really intense wounds and also increase risk for overdose. So in Ellensburg, the most commonly found drug by far was methamphetamine, with nearly all specimens, including some methamphetamine, and then followed a bit by heroin, fentanyl, and cocaine. No xylazine was found in our Ellensburg specimens. And then here, it's not surprising. This reflects what we saw with the self-reported data. Methamphetamine was found in the vast majority, sometimes all specimens, in our West Coast sites, and then less so in our East Coast sites. Whereas on the East Coast, we saw really high levels of cocaine found in specimens, and then fairly high levels of fentanyl as well. That, of course, tracks with what we were seeing with the self-reported data for both injection and non-injection of drugs. And then interestingly, we saw the highest proportion of specimens, including xylazine in New Haven. That is what we would expect based on what we've seen with xylazine's kind of path across the country. And so, yeah, they weren't super surprised to see that, but still, pretty stark differences between the sites. And I just wanted to give a shout out to an Epi PhD candidate, Caitlin Zinsley, who is analyzing these data. She shared this wonderful heat map with me, and this will be included in her dissertation. So more from Caitlin to come. She's doing some pretty cool analyses with these data. So then moving on to HIV and hepatitis C testing. First, the majority of our participants reported having ever been tested for HIV prior to the survey, and 29% of those who are HIV negative had tested in the past year. So that was actually, pretty low. We would recommend testing every year for these folks, and so pretty low levels of HIV testing. Although, again, this was a lot of this data was collected in 2021, and we know through other research that HIV testing virtually disappeared in a lot of harm reduction programs during and throughout the pandemic. And so it's really not that surprising to see these levels as low as they were during this particular snapshot in time. Our prevalence of HIV based on our actual testing data was 3.3%, and that ranged across sites from about 2.5% to a little over 4%. And that's actually lower than what we see in our NHBS surveys, which are all conducted in urban areas. In the most recent NHBS survey, they found a prevalence of about 6% among people who inject drugs. And so we have people who don't inject drugs and we're not in urban areas. And so that likely explains the lower prevalence. And then looking at hepatitis C, 21% of our participants had chronic hepatitis C. 1% had acute hep C, and then that ranged a little bit more across sites with either chronic or acute hep C being found in 9% to 37% of participants. Okay, we did see that injection equipment sharing behaviors were reported by a minority of participants. So these are behaviors that can very much increase risk for HIV or hepatitis C transmission. 21% of people reported receptive syringe sharing, so it's using a syringe after somebody else has used it. 25% reported distributive syringe sharing, so that is giving a used syringe to somebody else to use it. 29% reported receptive equipment sharing, so that's things other than syringes like cookers, water, cottons. I suppose pipes would be included here. Or sorry, this is injection equipment, so not pipes. And then 19% of people reported that they had divided drugs with a used syringe. So that could have some risk for transmission. But, you know, overall, I would say relatively lower levels for these outcomes. Again, a lot of these folks are people who are getting services at syringe exchanges or syringe services programs. So might not be entirely surprising that these levels are relatively low because these folks are receiving those services. We asked about overdose and overuse of different drugs in the past 6 months, and we found that 31% of people self-reported having had an opioid overdose in the past 6 months. And then that was in contrast to stimulant overuse or overdose. There aren't great questions about this. And so we had to come up with how to ask about it. And so we asked about if people had ever had a bad reaction and needed to seek care. So 9% reported that they had had a bad reaction to meth, and 8% had had a bad reaction to cocaine in the past 6 months. As hopefully everyone on this call knows, naloxone is a medication that can be used to reverse an opioid overdose. And we were really pleased to see that the vast majority of participants had ever heard of naloxone, and the majority had acquired naloxone in the past 6 months. And a full 35% had used naloxone on somebody in the past 6 months. And then unfortunately, we also found that 32% of people had been in a situation where naloxone was needed, but it wasn't available. So there's certainly still substantial amount of unmet need for distributing naloxone and making sure that folks who need it have it. And then finally, we asked about substance use treatment, both need for substance use treatment as well as actual use and participation in treatment. So overall, in our full sample, 65% felt like that they needed treatment for their substance use disorder. So 2/3 reported that. And just over a third reported having received some treatment for their substance use disorder in the past 6 months. So you can see a big gap there where a lot of folks are reporting a need for substance use treatment, but haven't actually received it. Then when we look at just those who use opioids, 34% of them reported that they had taken a medication to treat opioid use disorder in the past 6 months. And 24% had tried to get a medication to treat their opioid use disorder, but were unable to. So for those of you who aren't familiar, we do have good medications for treating opioid use disorder. So these are treatments like methadone or buprenorphine, which there has been a lot of push to increase in communities. So clearly we still have a lot of unmet need there as well. And unfortunately, we still don't have good treatments for many other types of substance use, including stimulants. Okay, so that was the last, I guess, meaty data slide I wanted to share, but I wanted to also talk a little bit about our site experiences, because this was a demonstration project and we of course had some data objectives, but we also had an objective of seeing and experiencing what it would be like for syringe services programs themselves to implement a project. And I showed you through our recruitment data that they were successful at recruiting participants into the survey. So, that was demonstrated. But what was also really neat about this project is that there were a lot of additional outcomes that programs had that came from the funding and the capacity building that staff were provided to conduct NEXUS. And so I wanted to share a little bit from each site about what changed for them. We actually were able to participate at the National Harm Reduction Conference in San Juan, Puerto Rico last fall, and we sent somebody from each site to come, and they participated on a panel and they were able to share their own experiences. And so this basically comes from that presentation. So first in Ellensburg, Washington, I just have to say, we were so happy. Ellensburg, Washington was the first randomly selected SSP that popped up on our list. And we could not believe how fortunate we were because they were in our state. We could actually go there, but it truly was random that they came up first. And this was our small rural site. They were only open 2.5 hours a week when we reached out to them. But because of our funding, they were able to be open 2 full days a week, up to 14 hours. And they were able to maintain that. They were able to get sustained funding after our project left because, their funders, their health department had recognized how much good that was leading to. So they were able to extend their hours. They saw an increase in their overall traffic during the project period. And for the first time, they were able to offer free testing and linkage to care. So they had not done that before. And so this project built up that capacity for them. And so then on the other side of the country, we worked with the Yale SSP in New Haven, Connecticut. That was a very different project to work with because they had a lot of experience with research. And so for them, it was somewhat easier to implement. But this protocol was new and different for them. And so they did face some, unique challenges. And they also saw some really great benefits. They were able to provide hepatitis C treatment to over 1/4 of their participants because they had HCV treatment on site and they were able to just move them over to a different room and start treatment. And so that was a really, really great success. And they also used their data to advocate for syringe vending machines. So that was a really great use of their local data. Then in Madison, Wisconsin, we worked with an FQHC called Vivant Health. Their syringe services program had originally been just a really small part of their overall programming. And so this survey actually, in some ways, overwhelmed their site. And you can see that in their numbers. They had a huge increase in the number of clients. They had a big increase in the number of HIV tests. They had an incredible increase in client diversity and also in PrEP referrals. And so once they were able to manage crowd control and kind of triaging people, it really, really built up their syringe exchange program. And so that was a big success for them. In Wilmington, North Carolina, we worked with one of the sites within the North Carolina Harm Reduction Coalition. So this is a grassroots SSP. They didn't have prior research experience. They were able to use their local data to demonstrate client food insecurity and get funding for that. And they were our site that had the highest number of or among the highest numbers of new HIV diagnoses and certainly of acute Hep C. And so they did already have a linkage to care coordinator on site. And so they were able to link folks to care who had never been diagnosed before. So that was great. And then finally, are two of our West Coast sites. In Sacramento, California, we worked with a grassroots SSP called SANE. They had 5 new reactive HIV tests. And so they were identifying quite a few new cases, and this really helped them build up their linkage protocol and establish connections with their health department and local providers around HIV. They increased their HIV testing and linkage to care, and they had just opened their program at the physical site where they conducted NEXUS. And so NEXUS was able to help them build relationships with their community and bring in a lot of new people through the doors. And so that really helped them, get their foothold with their new site. And then last but not least, in Missoula, Montana, we worked with Open Aid Alliance. And they were the site, as you probably saw in their drug testing data, they had 100% methamphetamine, found in their specimens. So they have a lot of methamphetamine use, and they were able to use this data from this survey to increase participation in their safe smoking program. They conducted more HIV tests during this survey than their previous 3 years combined, and they were able to hire an ER nurse who now stays on and provides wound care for their clients. So overall, we were just thrilled with all of these. I don't know if they were unexpected, but in some ways they were unexpected benefits of this project. But it really showed that when we give money to programs and we invest in them and train them adequately, they're able to do this important work. So in conclusion, with Nexus 1, I already mentioned that first bullet point. And I did mention, though, that sites did receive all of their raw data. So they have that now, and our team is available to provide technical assistance to them if they want help with additional analyses. As I showed you with the data, most participants used both injection and non-injection drugs. And so that data really highlights that SSPs need resources and support, including money, to provide safer smoking supplies. I showed you that stimulant opioid use is high, and it does vary a lot geographically. This impacts overdose prevention efforts, like, where to really focus naloxone. It shows or it actually ties into the potential impact on retention and treatment for opioid use disorder, where we have, not me personally, but others at the University of Washington have found that folks who are receiving medications from opioid use disorders, but also are taking methamphetamine, are less likely to be retained in treatment. And just in general, we need more treatment options for stimulant use disorder. And then finally, bring this back to HIV. Our HIV prevalence was relatively low, so that's a good thing. But we did identify some pockets of new cases. And we were excited that this survey really helped build up HIV testing at a time when it had declined so much at many SSPs due to COVID. So I mentioned that NEXUS was a demonstration project, and because we were successful with the first round, we were able to receive a bit more funding to conduct a second round of NEXUS. And so I just wanted to give you a few little data points about that. So we were able to fund 3 more sites for NEXUS 2. Now, interestingly, if you remember, for NEXUS 1, we were not allowed to pick sites that were in NHBS jurisdictions. But for NEXUS 2, the original intention was to compare NEXUS data to NHBS data to see if we conduct the survey in the same jurisdiction as NHBS, but using the NEXUS protocol, do we get similar or different results? And so we selected sites in 3 NHBS MSAs. One is in Newark, New Jersey. One is in New Orleans, Louisiana. And then the other one, it's a bit of a stretch, but it's outside of Indianapolis, Indiana. It's in a small town called Anderson. So it's technically in the NHBS catchment area, but it's pretty far outside of Indianapolis. Believe me, I've driven there, so it is far from Indianapolis. And so that one, we're not expecting a ton of overlap, but it's still in the catchment area. We actually had funding for 4 sites, but our 4th site dropped out at the last minute. So we ended up only having 3. And so the only data I'm going to share with you about NEXUS 2 is where we are with respect to recruitment and then overlap with NHBS. So if you look at that column with the N label on the top, as of last week, we were at 237 for New Orleans. Their goal is 300. So we expect them to get there in about a month. Newark, New Jersey is at 149, and they also have a goal of 300. So we're expecting them to get there by about mid-November. And then Anderson, Indiana, a pretty rural site, their goal was 150, and if they haven't reached, they're expecting to reach it this week. So they're going to be our first site that has completed. They're a really awesome site, and they're doing a great job. And so we ask each participant if they participated in NHBS, and I don't know if it was my hypothesis. My hypothesis was not that there was going to be that much overlap, but the CDC really expected there to be a lot of overlap. But as you can see, we're really not seeing that. NEXUS is bringing in largely a different group of people. About less than a quarter of people in New Orleans and Newark reported participating in NHBS, which would have been just last fall. So it's not too long ago. But most people did not participate in NHBS. And then not surprisingly in Anderson, very few people participated in NHBS, but that's so far from Indianapolis, we didn't really expect there to be a lot of overlap. So our evaluation goals are changing a bit. So I don't think there's going to be as much focus on the overlap, but we'll still take a look at it. But again, just showing that when we support and train sites to conduct NEXUS, they've been able to do a really great job. So that was my last data slide. I'm not going to read these. I have 3 slides like this just to highlight how many people have been involved in this project at the UW. We have had, I think it's 20 or almost 30 different interviewers. A lot of folks at CDC. We've had some external partners at NASN and NYU. And then at our 6 NEXUS 1 sites, took a village at each of these sites. And then at our 3 NEXUS 2 sites, a lot more folks. So we've worked with amazing people through this project, and I think we've learned a lot. So I'm happy to answer questions now. It looks like we have plenty of time. So thank you.